All right, good evening, everybody, and welcome to this month's Quality Improvement Committee meeting. We actually have a lot to talk about today. We've been charged with a pretty big project. As you may know, that we've had quite the increase in readmissions here at DHRA for our CHF patients, to the point that it has actually affected our reimbursement from Medicare for these patients, which, of course, in these financial times is not something that we want to be handling. So we need to look at what we can do to focus on this and improve these metrics. So I'm not sure if everyone here knows each other. My name is Melissa, and I'm the Director of Quality Outcomes, if everyone else would like to introduce themselves.
Hi, I'm Audrey. I'm the Quality Improvement Manager.
Hi, I'm Shannon, and I'm the CHF coordinator here at the hospital.
I'm Shay. I'm a DRHA case manager that works on Quality Improvement Committee.
And I'm Kimberly, and I'm the Nursing Informatics Officer here at DHRA.
Great, welcome everybody. So a little background here. So for preparation for our meeting, I did a little bit of research about this topic. Some of the information I have read, a lot of it has come from Gallagher and Rowell's article in 2003 from Nursing Administration Quarterly. It talks about how the provision of outcome-oriented and cost-effective care can't just be a goal anymore, it's a mandate. There's a lot of financial incentives tied to it. So hospitals need to evaluate the relationship between the cost of care, the process of providing care, and the quality and desired outcomes of the care that we're delivering, which creates an increased nursing accountability for the outcomes of care. The article also talked about how the American Nursing Association initiated a nursing patient safety and quality initiative, and that's based on the premise that all nurses must become more knowledgeable about quality outcomes, benchmarking, and other data measurements. And then the article also pointed out that only 15 to 20% of clinical interventions are supported by scientific evidence or evidence-based practice. So I think there may be a big opportunity here at our organization as far as looking at how much of our clinical interventions are supported by evidence-based practice. Some other interesting information I found from Mueller et al. In 2013 from the article on medical care. CMS pays for performance based on quality outcomes, and there's penalties for low performers. And included some of the metrics that we're talking right now are the readmission rates and mortality measures. So what was interesting is the article talked about how large teaching hospitals such as ourselves here at DHRA actually have a little bit more of a complex challenge with this, because teaching hospitals, we tend to care for sicker and more complex patients, which tend to mean higher readmission rates. However, we tend to have better quality outcomes as far as lower mortality rates. So we are keeping these patients alive, but we're seeing them more often here in the hospital. Looking into some ideas for programs, Ash et al. In 2005 from their article on medical care talked about how nursing and case management programs show the most promise, and they're focusing on costs and decreasing of readmissions. Programs that were more focused on the physician or facility-driven failed to improve quality indicators. So I think, again, this has a big nursing impact. Further, Smith in 2013 from their article on med-surg nursing talked about that pinpointing readmissions for CHF patients is an ongoing pursuit on a national level. There's been many QI projects in place that focus on poor communication, med reconciliation, ineffective education, patient noncompliance, inadequate discharge planning, and they show a varying degree of success. So again, another opportunity for evidence-based practice interventions on our part. Another part that their article mentioned, which I thought was interesting, because I know there's a group here at DHRA looking at telemonitoring implementation for CHF patients. showed that their review of data showed that intervention to be conclusive. So I think that we have some more work to do with that as well. So I look forward to hearing what the rest of you have to offer as far as ideas for improvement.
Thank you. I just would like to expand on what Melissa was saying and provide some more incentives for tracking this quality data and creating this report. From the ncqa.org website, it states that data collected nationally between 2009 and 2012 and reported by the Department of Health and Human Services on Hospital Compare showed that heart failure patients actually had the highest rate of readmission, and that was 23% when compared to other conditions such as acute myocardial infarction, chronic obstructive pulmonary disease, and pneumonia. In October 2012, just as you were saying, Melissa, the Centers for Medicaid and Medicare Services, also known as CMS, began reducing Medicare payments for inpatient prospective payment system hospitals that had excess readmissions. And that was off the Medicare.gov website. Also, in reviewing the article Claiming the Future of Nursing Through Nursing-Sensitive Quality Indicators by Gallagher and Rall, it's clear that payers are demanding higher quality care at a lower cost, and this is causing some decreasing satisfaction rates, both patients and nurses, with the nursing care that's being provided and demanded. Using these quality indicators that we'll be collecting, we can develop evidence-based care and direct the changes that need to occur. We can also create an environment of continuous learning and improvement, which can replace ones in the past that have been more like finger pointing and blame placing. Also, by creating this report, we can identify some outcomes of patient care that was received rather than the perceived patient care that was provided. By looking at that, what was actually the patient received, the care that the patient felt they received, we can adequately address the issues that are affecting some of these readmission rates for the CHF congestive heart failure patients.
That's great, Audrey. As the CHF coordinator here at the hospital, it's very important. Obviously, my as far as patients with heart failure and decreasing our readmissions, in the U.S. National Medicine National Institute of Health, there was an article written by Carol, Casey, and Giordetto and Jay, and they stated that despite enormous advances in the medical management of heart disease, that heart failure persists as the leading cause of hospitalization in our elderly. And so in the same article in 2007, they spoke about the Joint Commission that has implemented a number of quality care performance indicators based on guidelines, and those are measures that are endorsed by the Center for Medicare and Medicaid. That's been a national benchmark for measurement of public reporting for healthcare providers. So I just wanted to talk a little bit about that. In preparing this report that we've come together to discuss today, I actually used a model that was provided by the Agency for Healthcare Research and Quality, and it kind of gives a guideline on how to prepare a report. And so based on that today, I'm going to be using some examples of the national and state benchmarks that can be found on various websites. One of those is Medicare Centers for Medicare and Medicaid Services. It's www.cms.gov. And under the specialty quality measure sets, you can find different measurement factors that are measured by the hospitals. And then I know later on Shay's going to talk a little bit more about exactly what data is going to be measured and where you can find that. In the supported system that we do have here at the hospital. So we do have that infrastructure needed to find those. I also wanted to share another quote, and it states, nursing nursing quality indicators can be of value in the development of evidence-based healthcare report cards and can be used to direct change. In summation, we must, as they say, work together to bring about a positive future for nursing by utilizing nursing-sensitive quality indicators. And that was by Rita Munley Gallagher, Patricia A. Rowell, and that was in 2003 in the Nursing Administration Quarterly. So I look forward to working with you on the committee in order to complete this report to, in fact, show that we do have the technology infrastructure that Shay's going to be talking about later, and the specific data that we need for this report. There's different systems that have different requirements according to the NCQA, and I think that Kimberly is going to go ahead and talk to us a little bit more after Shay does. So, Shay, did you want to speak about this?
Yeah, thank you, Shannon. So, like I said, I'm a case manager on our coronary heart failure team that monitors our readmissions and is working on that. So, I just wanted to share with you guys a little bit more about where exactly we can find some of this information. One of the really helpful places is actually just on the hospital's main page on the internet. And you can go to the Departments and Programs tab and then click on Quality Enhancement Services, and there will actually be a page with a whole bunch of information on there. There's some quality department contact phone numbers, there's a balance scorecard, and then there's a CHF quality measures document on there. There's also some external links that are helpful for Medicare.gov, for the National Committee for Quality Assurance, for NSC Healthcare Effectiveness Data and Information Set, and also for the National Database of Nursing Quality Indicators. And on the HEDIS one, you can actually have access to the Interactive Data Submission System for reporting. So one of the things that we do on our committee is, like I said, monitor readmissions specifically within 30 days. So when a nurse in the ER gets a CHF patient that has been readmitted in less than 30 days, that should trigger them to fill out a MIDAS report, and our committee can get access to those incident reports through the Press Ganey website. One of the other things that we also look at is a CHF clinical pathway, and I just want to show that to you guys real quick. So as you can see, it goes through day 1 of admission, all the way through the days in the hospital and then the day of discharge. And one of the things we look at are the laboratory and diagnostic values. So those can be found in the EHR under the nursing workflow. You can see what labs were on admission and what the diagnostics looked like at that time. We can see what the nursing orders were, and also in the nursing workflow section of the EHR is where you can find things like the I's and O's that were recorded, the daily weights, what the orders were, like activity restriction and diet restrictions. Through Epic, we can look at the medications that they are on in the hospital and just, you know, the MAR for what we were giving them. And then we do start looking at discharge readiness from day 1. So you can follow that through days 2, 3, 4, however long they stay. And then in the EHR, you can find what their labs were, what their diagnostics were on discharge, whether or not we discharge them on a ACE inhibitor or a beta blocker. And then in the after visit summary is where we would look at things like their admission medications, what they came in on, and then what the doctors are discharging them on, and then also, you know, what the case manager plans for home health and that sort of care coordination thing. So I think that's a really helpful clinical pathway, and actually have a some statistics from the Journal of Healthcare Quality in 1995. Is there still a screen sharing? Hang on. Did it go back to me?
You're good.
Yeah? Okay. I just didn't know if you wanted to stare at me or my data. It's by Estes et al. From the Journal of Healthcare Quality, and it just talks about how a hospital actually implemented one of these clinical pathways for AFib, and in 1 year they were able to decrease their 30-day readmission rate from 24% to 16%. So I think that this is something we really need to focus on in trying to decrease our readmission rate. One of the other things we also looked at on our committee is the HCAP scores for consumer satisfaction. And part of that is one of the questions that we ask the patients is how well do you feel like your nurses and doctors discharge medications. So I think that our scores on that indicate that we really do have a huge opportunity for improvement there as far as making sure the patients know the instructions for their discharge medications when they go home. Kimberly, did you have more on that?
Yes. I just wanted to add, as the nursing informatics officer, being able to use technology as a science in the health realm is our specialty. And according to Peterson and et al., the ability to distribute and exchange information from multiple sources is important to informatics, as well as research, public health, and other healthcare issues. The ability to find this information should be in patients' electronic health records. And what we need to look for in the EHR includes most recent admission and discharge dates, vital signs, daily weights, fluid restrictions, and any other factors that could contribute to monitoring for congestive heart failure. And also, if there is any public record, for the hospital on why there are continued readmissions, that information can be accessed as well. Something such as the hospital compare can be used for improvements of quality of care delivered by hospitals. And as far as us having the technology, we can develop the technology at DRHA. With the current EHR system, the system can be improved in order for the infrastructure to provide, the proper patient information. And also, Hospital Compare gives information on using government data and how the public domain does not require permission to reuse them. So we do have the capability of accessing that information as a hospital.
Fantastic. Well, thank you everybody for your input. It sounds like we have a pretty good start. We have sounds like we have the right infrastructure we need to get this started. I think some of the ideas for what data we need to start looking at have been really great. Shay, I really like the idea about the clinical pathways. That sounds very promising. Overall, just listening to what everyone has to say, it sounds like not only is this about collecting data, but it sounds like it's going to be a whole nursing culture change within the organization. So it'll be a pretty big undertaking, I think, to look at what outcomes we're not only measuring, but what evidence-based practice are we using to implement changes to our current process. A little comment on that from an article from Barrett et al. In 2009 from Nursing Administration Quarterly. They talk about successful teams and that they found that the most successful teams focus on building trust, and they identify and clarify roles, engage the staff in decision-making, and managers who have the ability to clearly articulate trust and belief the potential for improvement is critical. They also talk about how the ultimate measure of success is sustaining process changes that drive metrics. So I think not only do we need to work on within our group as far as the reporting and data that we're building, but work with our managers as far as and nursing leadership as far as what changes culturally we need to make to get staff on board to make this project successful. Does anyone else have anything to add before we conclude our meeting this month?
I think so, other than it's been great working with you again.
Always fabulous working with you all.
Great job, once again. Good meeting.
All right. Thank you all, and I'll see you next month.
Thank you.
Thank you.